Psychology here, but I'm also co-chair of our. We got it. I'm also the DEI Advisory Board co-chair for our executive leadership team, and our ELT was really supportive of bringing this film here, and we are so grateful to them. So let me start by introducing Dr. Kene-Ewulu, who is our acting chief of staff at VA Northeast Ohio. She is a board certified internist and member of the American Association of Physician Leaders. Her previous experience includes many clinical years of practice as a general surgeon, hospitalist, clinical faculty, and physician leader. She's on a detail from her position as director of Vision 7 Clinical Resource Hub, and she's a member of the American College of Healthcare Executives, and she's a fellow of the Royal College of Surgeons of Edinburgh, and is certified by the American Board of Internal Medicine. She's in her 12th year with the VA, serving in different roles as a primary care physician and team lead, hospitalist, clinical director, interim chief of staff at Carl Vinson VA HCS Dublin, Georgia, and interim chief of staff at Atlanta VA HCS Georgia. Dr. Kene-Ewulu is a graduate of the Healthcare Leadership Development Program, Business 7 Clinical Leadership Executive Training Program, and is a Leadership VA 2021 Fellow. Her professional interests include organizational excellence, innovation, building teams, and team productivity. And she has a whole lot more. I'm going to move on to the next person. So I'm very appreciative of Dr. Sherry Williams joining us. She is a professor of medicine at Case Western Reserve University School of Medicine. She completed her undergrad and graduate education at Johns Hopkins University and earned her MD from the University of Illinois at Chicago. She completed internal medicine residency, chief residency, and fellowship in pulmonary critical care at Wayne State University, Detroit Medical Center. After spending several years in private practice and 21 years at the Metro Health System in Cleveland, she joined the VA in June of 2022. Locally, as a Cuyahoga County Board of Health Board member, she's been a strong advocate for health equity. She is a respected clinician, educator, and medical leader with expertise in smoking cessation, sarcoidosis, and critical care. In her spare time, she enjoys family, cooking, and traveling. And we want to also extend a very warm welcome to Dr. Amy Hise. She is a physician on the acute care service and a researcher at the Lewis Stokes Cleveland VA Medical Center. She holds an academic position of professor of pathology and international health at Case Western Reserve University. Her undergrad training was in biomedical engineering at Northwestern University, followed by a master's in public health with a focus in international and family health from UCLA, prior to earning her medical degree at the George Washington University Medical Center. After residency training in internal medicine at University Hospitals of Cleveland, she completed a research fellowship in infectious disease at Case UH, focusing on innate immune recognition of filarial parasites. Her current VA-funded research focuses on the activation of innate immune responses by fungal pathogens. She is active in the field of diversity in medicine, serving on many committees, including the VA Northeast Ohio DEI Advisory Board, chairing the SOM Committee on Women and Minority Faculty, and mentoring students, trainees, and faculty. Nationally, she is a longstanding member of the American Medical Association, and much more. So obviously, we have a very distinguished panel. And I am going to start with a question, and any of you that want to start can answer first. What are your immediate thoughts about the film and what resonated with you as it pertains to your role at the VA? Any of you can.
So I think as you previously heard, I actually did my training at the very place that was featured in the film. In fact, many years ago in the early 90s, I was the chief resident of Detroit Receiving Hospital and spent 7 years in Detroit. And so my first reaction was, wow, lots of memories flooded back. And how sad to see that the institution that trained me struggled so. But then my second reaction was, I think so many of us all across the country struggled. Right here in Cleveland, we struggled. And I think one of the things that was very clear was that a lot of the things that we struggled with were things that had been set in motion many, many years ago. And I found myself saying how far we have come to even be here today having a discussion, because I can assure you, as chief resident in Detroit in the early 90s, we never thought about or would have had a conversation such as this with respect to health equity. So I found myself being encouraged that some progress has been made, but boy, oh boy, do we have a lot more to do.
I think for me, Sherry and I were talking about this before the discussion. For those of us who were on the front line in the spring of 2020, there is a little bit of a PTSD watching this film, because, it was such a difficult time. As a physician, our limits were reached, and we were faced with that every day. The limitations of what we had to offer patients, the limitations of the system, the limitations of our country's response and our global response to this horrible pandemic. I mean, as an attending on the COVID service during that time, I have never had so many patients die on 1 week of service. It was really just awful. And, so this film brings that back. I think, stepping back from the COVID story, using the COVID pandemic and what has happened, the disproportionate death rate of Black Americans to this disease, as an illustration of underlying problems with health disparities. It's a very effective tool for that. But we've been dealing with this for decades, and it affects so many other aspects of health and how people access medical care, that I think we should use this as a launching point to, really talk about where we are at now, acknowledging what's been done in the past, but most importantly, where are we going to go in the future, and how are we going to change things? Because I think if we just talk about how awful this is without really listening to this as a call for action, and really thinking about how we as a health system serving our veteran population can change things moving forward, it's a lost opportunity.
And then for me, this is my second go around, so thank you for having me back on the panel. I think one thing that jumped out the first time, and I want to reiterate that, but perhaps add to that, is understanding the root of a lot of the things that we face. And I think it is even more important now in the face of what Dr. Hise and Dr. Williams have mentioned, that we go back to understanding the roots, because sometimes we get into actions and reactions and responses without even knowing how we have been programmed. So if we understand what is at the bottom of the program, perhaps we, with our own, self-determination, might decide, I don't want to be part of this, and maybe that might change the way that we respond to things. But I also want to add that we all recognize that COVID was that time, that horrible time. Still not out. We're not out of the woods yet, but that horrible time was a magnifier of the inequities that existed. It makes you wonder, where else do we have inequities, and what catastrophes are we waiting on before we identify those?
I want to also invite the audience, if you have any questions for our panelists, or if you want to make a comment, please do so in the chat. One of the comments made in the film was that zip code determines life expectancy. When we think about the city of Cleveland and even Cuyahoga County and the diverse communities that comprise the second most populous county in Ohio, what can we do to reverse that truth?
I mean, I'll start, but I'm definitely interested in hearing Dr. Williams' thoughts on this matter with, where she came from prior to joining us here at the VA. I mean, it's such a complex problem. There's no easy solutions, right? If it was easy, it would have been done. I think it requires cooperation and collaboration amongst multiple groups. I think that with change in local government, it's a great opportunity to engage with our local government and our local leaders as a healthcare institution. But I think we also have to band together with other entities in the city. It's not going to be easy to change things. Some of it is historical. Some of it is, this is how things have been done in the past. Some of it is the hopelessness of thinking that we can make dramatic change. And I think we would try to look past that hopelessness and really engage with others, including, the community itself, to assess what the needs are of our community. Our patient population here, is a different population than what some of the other healthcare systems serve. Part of it is that we do have that sort of universal healthcare coverage model here at the VA, which really provides a unique opportunity for people to access care. And I think that puts us in something of a unique position. But I think that, when we look at the city as a whole, we look at Cuyahoga County, things can be done better, and we should partner with others to try to make that happen.
I think to Dr. Hise's point about partnership, one of the things that, and I'm speaking more from my perspective as a board member for Cuyahoga County Board of Health, that the public health department learned and continues to strive to do is really that of partnering with people in the community, with organizations and community staples like the church, for instance, that the people in the community trust, right? One of the things that we saw in this video, this movie documentary, was that trust and communication become really, really important when you need to address historical mistrust, and when you need to reach a community that has a history of mistrust and has significant complexities, to Dr. Hise's point, and intricacies that really require someone who is in touch with those nuances and intricacies. One of the commentaries in the documentary is, it's not about going into the community and saying to people, well, here's what you need to do. Here's how to do it. It's about dialoguing with the community about what are the needs and how best can we meet those needs, and working with those in the community to help get it done. I think the other thing is really something that we as an academic institution, be it over at Cleveland Clinic or UH or the VA or Metro Health, we as academic institutions know the value of data, know the value of evidence-based medicine in terms of, here's what the data is showing us, the data on vaccination rates, the data on, the disparate outcomes. These things become important in terms of sort of setting out a plan or a course of action. And I think those of us who understand why it's important to have data and to really focus on evidence-based approaches know that to a certain extent, the way that we will find our way here is to, as Dr. Joss said in the video, is what does our data tell us? What does our own data tell us? And even here at the VA, where some of the issues, as Dr. Hise has pointed out, like we have great coverage, we have great resources for our veterans, it becomes important for us to continue to look at our own data and to continue to try improve upon, what has been our experience. I think finally, we have at this institution and other institutions that are academic institutions, we have a somewhat of a moral obligation to have our trainees come to embrace that we have to do better, and that there's a real need going forward to have challenging and yes, difficult conversations, but to be progressive in our thinking towards solutions.
Thank you. And I'll add that in addition to the VA mission of veteran healthcare, education, and research, we also have a fourth mission to the community. And I think we've learned in the VA since the Vietnam War vet era that we have to be integrated with the community. We are part of the community. The community is us. The veterans that we take care of are part of the community. So it highlights that even more. We are not separate from the community. The experiences we have, we share with the community, we learn from the community, and what happens there also happens, within or will affect the VA. I think those of you who were at the front lines during those terrible days of COVID would probably have had non-veteran veterans wanting to be hospitalized. We were in communication with the county hospitals and we're looking for beds in ICU. So we're one community.
Very important. One of the things that I noticed in the chat, someone was asking about, kind of pertains to our next question. And they were asking about, are there training for all the different hospitals on how to address the racial inequities through the nation, as well as having updating meetings? And our, next question was going to be, since your work often involves effective training of healthcare professionals to improve care provisions, what are a few evidence-based recommendations you'd provide to people in the audience who may be working in clinical or non-clinical capacities, but want to advance health equity through their role, their department, or their institution at large?
I think I can answer this from sort of two different hats that I wear. One as an attending who's training medical students and residents and other trainees. We do provide curriculum and we do emphasize things like unconscious bias. But I also make it with my training of the team on very patient specific. We try to bring in examples of how we react to a situation from our own background that might be different than a patient or families of a patient, and how important it is to recognize when those thoughts in our head come up that might bias our thinking and our interactions with patients and their families. And then also to have that open communication with patients and their families with a very open heart and an open mind in terms of what are their health beliefs, what are their prior experiences with the healthcare system, and what are their goals. Their goals might be different than our goals in terms of how we think about what they want for their healthcare. But then the second hat I think about is as a member of the DEI advisory board, where we've talked about diversity training and making that available to all employees at the VA. And really have made that something that we are working with the ELT on how to make that accessible, how to make that something that everybody has access to, but also that we're providing evidence-based training. And I think that's a really important aspect of this is everybody in the system, not just the medical providers, play a role in creating a welcoming and supportive space for individuals, both other employees as well as our patients in the community when they interact with the VA system. So I think there's a lot that can be done on that end as well to support how we create that welcoming and supportive space.
I like that. As you're passing the mic, I wanted to just say, sometimes what we've run into when it comes to training is providers not believing they need the training, not wanting to attend the training, feeling like the training is a waste of time. We also have many providers that I have heard with my own ears say, if we would stop focusing on race, the problem would go away. That part of the problem is we over focus on differences. So, what would you guys respond to that as well when as you go on and respond to this previous question?
So I think the VA has been somewhat of a leader with regards to diversity and inclusion issues over the years. Maybe we can do better. We know we can do better, but we don't have the same level of training and opportunities outside of the VA as we do in here. Matter of fact, I can understand why some providers may say to you, hey, we're focusing too much on this. There's TMS that we have to do that talks to us about generations and talks to us about, all the differences. But I think that perhaps being a little understanding about why people push back. And I think some of it is the pain of confronting yourself, right? None of us likes to look in the mirror. And we have to, I don't know what the answer is, but perhaps if we can address that, those of you who are subject matter experts in this area, how do we face ourselves? How do we, look ourselves in the face and say, I don't know this culture. How do I get to know this culture? How do I get to be learnable, right? I recall that when I was in a program, one of the didactics we used to teach was cultural competency. It was based on the VA TMS of cultural competency. And we had a resident in class who happened to be a medical anthropologist and educated us about cultural competency and introduced a new term to us about cultural humility. It was a bit of a painful pill at the time, but when we thought about it and talked about it, we saw, hey, you can't really become competent. Perhaps that is an overreach, right? Saying you can become knowledgeable about multiple cultures and competent in those cultures. Maybe what we really need to understand is that we need to be humble. I don't understand this culture, and then be open to learning about that culture. So as the subject matter experts, those of you in DI and, the professors in the room, plan and devise these curricula. Perhaps these are things that are areas that we need to be looking at. What is it that stops me from looking myself in the face? Why do I want to push back at DEI training? And by I mean, all of us. I'm trying to be humble here, right? So maybe we don't know the answers, but maybe looking at that part of our psyche might be the solution might lie in there. What do you think, Dr. Williams?
So I think, first of all of us, myself included, have biases, some that are conscious and some that are unconscious. So that is a given for all of us. And I think it's a bit of a slippery slope to sort of think that you don't have them, or that somehow as an individual I'm immune to having biases. That just isn't true, and can't be true, because we're all human and we are all products of our experiences. And the truth is that we never see ourselves the way that other people do. We never see ourselves the way that other people do. And so this is an opportunity for us to be better at what we do, right? So as physicians, as nurses, as pharmacists, as people in healthcare, our role in terms of what we do is to care for people. And if we're going to do our job in the utmost excellent way, right? So not mediocre or D+ work, but A+ work, then that requires that we learn how to take care of the whole person. And one of the things I've learned since I've been here and been very impressed with is, you know, the VA's sort of drive towards whole health, you know, and part of taking care of the entire person means trying to really understand why people may have certain trusts or mistrusts, why people may challenge or question a particular therapy or treatment plan. And so I view the need for training and really continued dialogue about issues of diversity, equity, and inclusion as really working towards being our best selves, working towards having the outcomes that we want to have for our patients. Do I want to deliver, you know, just okay care? No, I want to deliver excellent care. And so, you know, when I was at my other institution at Metro Health, we quite honestly took care of a lot of people who were Amish. Okay, so I need to learn and understand a lot about people who are Amish. Why? Because I want to make sure that I'm delivering the best care that I can. And I think all of us as healthcare, right? The emphasis on care, we want to deliver the most excellent care that we can. And that means embracing the whole individual. And so, yes, that means understanding and embracing where they have come from, their race, their ethnicity, their heritage, their cultural beliefs, right? So it's about being our most excellent selves and delivering the most excellent care and having the most excellent outcome. That's why we do it.
I love it. I love it. I have really enjoyed listening to our panel. I'm going to just give one final comment and then open it up to Jalise Thomas, who is the sponsor through the Clinical and Translational Science Collaborative at Case Western Reserve. But my final comment is that I think one of the things that the VA has pushed us towards is to not see our patients as them and it's us against them, or it's them and us. Instead, we are collaborating together on our patients' care. And the moment we do that, we can let some of our assumptions and biases about our patients go away. I loved in the film when they said, treat that patient like you would want your mother, your daughter, your husband, your father, your brother treated. Treat them the same way you would treat your family. And I think that's really key. Jalise, I'm going to open that up to you. And again, I want to thank my distinguished panel for being here today.
Thank you so much, Josephine. It's been a pleasure working with you and your team to bring this screening and panel discussion to the VA for the second time this month. You are closing it out for the 2022 year with us. And on behalf of the Clinical and Translational Science Collaborative at Case Western Reserve University, we appreciate everyone who has watched the film, who is participating in this discussion, our expert voices, and just know that, you know, for some of this may be the first step towards advancing health equity and understanding all the issues that were presented in this video, and those that were not. But let's just continue to be curious, compassionate, respectful, and, you know, want to make those connections and have those relationships with people, because that is truly how we will be leaders in envisioning what health equity looks like in Cleveland and beyond. So thank you, everyone, and Happy New Year to all.
Thanks again for coming. Bye-bye.